What if the defining symptom of a loose pelvic floor is actually a muscle that is working itself to the absolute brink of exhaustion?
Right. It sounds totally backward.
It really does. I mean, we are just so culturally conditioned to believe that when it comes to the pelvic floor, loose means weak and tight means strong.
Exactly, yeah. But if you look at the clinical literature, everything we've been taught about these sensations is, well, it's functionally backward.
It is. And that contradiction is exactly what we are dissecting today. So welcome to today's deep dive. We have a really fascinating stack of sources to get through for you today.
We really do.
Yeah, we are looking at clinical studies, specifically the multi-center DevelopS study, and we're pairing that alongside NHS guidelines and a whole wealth of current expert pelvic physical therapy literature.
Which is so crucial to understanding all of this.
Right. So our mission today is to investigate a totally counterintuitive question in women's health, which is, can pelvic floor overactivity actually mimic vaginal laxity?
I mean, it sounds like a paradox right out of the gate, doesn't it?
Yeah, totally.
Like, how can overactivity, which obviously implies tightness and tension, mimic laxity, which implies, a lack of tension?
Right, exactly.
So to understand this, we first have to separate the actual physical architecture of the body from the subjective experience of the patient.
Right, because when a woman goes to her doctor and says, things feel different down there since I had my baby, or things feel different since I entered menopause, there is this immediate assumption that something has physically stretched out.
Or broken, yeah.
Yeah, exactly, or broken. But the medical definition of vaginal laxity isn't structural at all, is it?
No, it's really not. Medically speaking, vaginal laxity, or VL, is defined purely as a subjective sensation.
Okay.
It is a reported feeling of looseness or a noticeable reduction in physical sensation. And we really have to clearly distinguish that feeling from something like pelvic organ prolapse, or POP.
Right, because prolapse is a physical, measurable event.
Precisely. Pelvic organ prolapse is the physical descent of the pelvic organs, so the bladder, the uterus, or the rectum dropping down into the vaginal canal because the supporting connective tissue has failed.
Which a doctor can literally see happening.
Exactly. They can measure the descent using standardized anatomical systems. If you have prolapse, there is a definitive structural change. Vaginal laxity, on the other hand, is entirely about what you are feeling, or, well, more accurately, what you're not feeling.
Okay, let's unpack this. Because if a woman is experiencing a profound lack of sensation, her instinct is going to be that the physical dimensions of her anatomy have changed.
Naturally.
She assumes the canal is wider, right? So there is less friction. But the sources highlight a massive study that completely shatters that assumption.
Yes, the DevelopS study.
Right.
The acronym stands for Description of Vaginal Laxity and Prolapse and Correlation with Sexual Function. This was a cross-sectional study involving 95 women. And the researchers wanted to test that exact instinct you just mentioned. They wanted to see if the subjective symptoms women were reporting, their feelings of looseness, which were scored on a standardized vaginal laxity questionnaire.
Right, the VOQ.
Exactly. They wanted to see if those questionnaire scores actually matched up with the physical reality of their pelvic anatomy.
So they put these 95 women on an exam table, took their scores where they reported feeling loose, and then took actual physical measurements of the pelvic tissue. How exactly do you measure that clinically?
The doctors did incredibly thorough physical exams. They measured two key metrics. First, the genital hiatus.
Which is what?
That's the distance from the external urethral opening to the posterior midline of the hymen. Essentially, it's the physical opening.
Okay, got it.
And second, they measured the midvaginal caliber, which is the actual structural width of the vaginal canal itself.
And if the cultural narrative were true, the women with the highest scores for feeling loose on the questionnaire should have had the widest midvaginal caliber measurements.
Exactly. That's what logic dictates,
Yes.
right?
Yeah.
But the results were stunning. The researchers found absolutely no significant correlation between a woman's subjective laxity score and her actual physical exam findings. None.
Wait, hold on. I need to make sure I'm getting this right.
Sure.
These women were coming into the clinic, filling out a standardized medical questionnaire stating that they felt incredibly loose. And when the doctors measured the physical width of the canal, it was completely statistically average.
Normal midvaginal caliber, normal genital hiatus.
Yeah.
The physical dimensions did not match the subjective sensation in any statistically significant way.
Oh, wow. So it's almost like it's like feeling a chilling draft in a room, even when you can visibly see all the windows are sealed shut.
That's a perfect analogy, actually.
But if the physical measurements, the actual structural width of the tissue are completely normal, where is the sensation coming from? I mean, you don't just feel a profound sensory change out of nowhere.
Right, there has to be a physiological catalyst.
Exactly. If the architecture is sound, what are we missing?
Well, if the physical structure isn't actually loose, we have to look away from the structure itself and start looking at how the muscles within that structure are behaving.
Oh, I see.
We have to examine the hidden world of muscle resting tone. And this brings us to the physiological reality of the hypertonic or overactive pelvic floor.
Okay, we hear so much about the hypertonic pelvic floor, the weak pelvic floor that supposedly causes leakage and all that.
Right.
But hypertonic isn't a term that gets thrown around casually. If I understand the literature correctly, a hypertonic pelvic floor isn't just a muscle that flexes, it's a muscle that basically refuses to turn off.
That's a really great way to put it. Normally, your pelvic muscles contract when you need them to,
Mm.
like to maintain continence when you sneeze or cough, for instance.
Right.
And then they fully relax when you don't need them. But sometimes these muscles enter a state of continuous protective guarding.
Guarding.
Yeah, the resting baseline tone of the muscle gets cranked up and it simply refuses to let go.
But what signals the brain to lock the pelvis down like that? I know physical trauma is a big one, like a severe tear during childbirth or recovering from abdominal or pelvic surgery.
Oh, absolutely.
Because the body senses a profound injury in the area and clenches the surrounding musculature to create a kind of organic splint, right, to protect it.
Physical trauma is certainly a primary trigger, but the sources are clear that it doesn't have to be a major medical or obstetric event.
Really?
Yeah. Chronic pain conditions like endometriosis or irritable bowel syndrome can trigger this guarding reflex too. And crucially, chronic emotional stress and anxiety are massive contributors.
Wow. So it's the exact same mechanism as someone who carries all their stress in their neck and shoulders, right?
Yes, exactly.
Like you sit at a desk all day, you're stressed about a deadline, and suddenly your shoulders are permanently hiked up by your ears. And you don't even realize you're doing it until someone points it out.
Precisely. The pelvic floor is a major repository for physical tension.
Sure.
Holding your breath under stress, constantly sucking in your stomach for aesthetic reasons.
Oh, people do that constantly.
All of these subtle everyday actions signal your central nervous system to clench the pelvic floor. And over time, that clenched state becomes your body's new normal resting tone.
Which has to be incredibly taxing on the tissue itself.
Yeah.
Let's think about the actual physiology here. If a muscle is constantly contracted 24 hours a day, it basically acts like a tourniquet on its own blood supply.
It does. And the numbers attached to this are just alarming. Our sources note that just a 10% increase in the resting tone of the pelvic floor muscles causes a 50% decrease in blood flow to that specific area.
Wait, what? A 50% drop in blood flow from just a 10% increase in tension?
Yes.
That's a massive physiological penalty for a very small amount of guarding.
It creates an immediate state of ischemia, which is a localized lack of oxygen.
Yeah.
Without proper arterial blood flow flushing the area, the cells just can't get the oxygen they need.
Right.
And more importantly, they can't clear out cellular waste.
So you get a severe buildup of lactic acid and other metabolic byproducts. Because there is no blood flow to wash the tissue clean, the lactic acid just, pools there.
Exactly.
It's essentially a perpetual localized muscle cramp.
It's exactly what it is. And that acidic environment severely irritates the nociceptors, which are your pain receptors, and the surrounding nerve endings.
Ouch.
The irritation causes pain. And how does the body respond to pain?
It guards the area even more,
Exactly. It clenches harder.
which drops the blood flow even further. It's a completely vicious, self-sustaining feedback loop. But here's the piece I want to connect back to the feeling of weakness.
Okay.
Think of it like a clenched fist. If I make a fist and I squeeze it as hard as I can nonstop for 3 hours, by the time I actually need to use my hand, say, to pick up a heavy suitcase, the muscles in my hand are so utterly exhausted and starved of oxygen that I can't grip the handle.
Right, yeah.
My hand functions as if it's incredibly weak, even though the muscles are technically incredibly tight.
What's fascinating here is how that exact clenched fist scenario presents in a clinical exam room. Because these hypertonic pelvic muscles are exhausted and locked in a shortened state, they have completely lost their range of motion.
Makes sense.
So a doctor might ask a patient to actively contract her pelvic floor muscles during an exam. The patient tries, but because the muscle is already clenched at its maximum capacity, it can't contract any further.
There is no runway left.
Exactly. There's no range of motion. So to the patient, and sometimes even to a clinician who isn't specializing in pelvic floor physical therapy, this lack of movement looks and feels exactly like extreme muscular weakness.
Wow.
Functionally, extreme tightness presents identically to extreme weakness.
Okay, I follow the logic of how a tight muscle mimics a weak muscle, but I want to push back on the specific symptom of vaginal laxity.
Okay, go ahead.
If a muscle is locked in a hypertonic spasm, that creates tension. Tension creates friction. Friction is the exact opposite of looseness. So physiologically, how does a cramped, tight muscle trick a woman's brain into registering the sensation of being loose? You're losing me there.
It all comes down to the nerve irritation we just discussed. A major hallmark symptom of vaginal laxity, as reported by patients, is a complaint of reduced sensation during intercourse.
Okay.
Women feel like there is a profound lack of responsiveness. Now remember that ischemic environment, the 50% drop in blood flow and the pooling lactic acid.
Right, the tissue is suffocating?
Yes. And when tissue is suffocating, it cannot engorge with blood normally during arousal. And more critically, the nerves embedded in that highly acidic, tense tissue become severely blunted.
Oh, I see.
They aren't firing correctly. They aren't transmitting tactile signals back to the central nervous system effectively.
So the brain is receiving a muffled signal. It's experiencing a sensory dead zone.
Yes, the brain receives this blunted, unresponsive signal.
Yeah.
And because human beings naturally associate a lack of friction, a lack of contact, and a lack of responsiveness with the concept of looseness, the brain translates that nerve numbness into the subjective sensation of laxity.
That is a staggering translation error by the nervous system. Yeah. The brain is feeling nerve numbness caused by a suffocating muscle spasm and translating it into the word loose.
It is a translation error, yeah.
Huh?
And the sources provide undeniable proof that this is exactly what is happening.
They do.
Yes. If we go back to the developed study, we find what is arguably the most clarifying piece of data in this entire deep dive: the partner paradox.
Yes. Let's break down these numbers because this completely recontextualizes everything.
Remember, all 95 women in this study were reporting subjective feelings of laxity. They firmly believed they felt loose.
Right.
The researchers then asked these women a very simple question. Has your sexual partner ever commented on your vaginal tone?
And logic dictates that if these women were truly physically loose, lacking friction, their partners would be the first to notice the structural change.
You would assume so, yeah. But the data showed that only 28% of the partners had ever made any comment about vaginal tone at all.
That in itself is telling. Over 70% of partners noticed absolutely nothing different.
But the real revelation is within that 28% who did comment. Of those partners, the vast majority, 21% of the total group, commented that the vagina felt tight.
Wait, really?
Yes, only a tiny fraction, a mere 7%, actually corroborated the woman's feeling and said it felt loose.
Here's where it gets really interesting. Look at the disconnect happening in real time. The woman is experiencing a total lack of sensory feedback. She feels this ischemic dead zone, this numbness, and her brain interprets it as, I must be loose.
Exactly.
But the physical anatomical reality experienced by her partner is a wall of exhausted hypertonic clenching muscle. The partner is feeling the actual spasm.
It proves that our cultural understanding of what loose and tight feel like is completely inverted.
Completely upside down.
We associate tightness with strength, health, and heightened sensation. We associate looseness with weakness, damage, and numbness. But in the pelvic floor, the feeling of looseness is frequently the primary symptom of a muscle that is trapped in a painful, hyperactive spasm.
Which brings us to a massive clinical problem.
Right.
Because if our perception of what is happening in our own bodies is perfectly backward, then our go-to at-home treatments are probably backward too.
Oh, they definitely are.
If a woman misinterprets this numbness as weakness, what is the immediate cultural reflex? What does every magazine, every postpartum blog, every fitness influencer tell her to do?
Do your Kegels.
Right. Download an app, squeeze at the stoplight, just strengthen, strengthen, strengthen to fix the weakness.
Yep.
But based on the physiological reality we've just laid out, if the pelvic floor is actually hypertonic, what happens when you force it to do a Kegel?
It is an absolute catastrophe for the tissue. So, yes, we have to look at the mechanics. If your pelvic floor is hypertonic, it is already clenched, exhausted, and suffocating in lactic acid. Doing Kegel exercises on a hypertonic pelvic floor is like taking a bicep that is currently locked in a severe, agonizing cramp and forcing it to do heavy bicep curls.
Oh man, it's just throwing gasoline on the fire. You are asking an exhausted muscle to work harder without ever teaching it how to rest.
Exactly. When you force a Kegel on hypertonic tissue, you actively increase the lactic acid buildup. You further restrict the already compromised blood flow.
Making the ischemia worse.
Yes, and you heighten the nerve irritation. Doing Kegels on an overactive pelvic floor will make the underlying dysfunction significantly worse. It frequently escalates mild discomfort into severe chronic pelvic pain, urinary urgency, and severe pain during intercourse.
So, what does this all mean for the actual treatment protocol? If strengthening is the exact wrong move, if doing a cable is actively harming the patient, how do you treat a hypertonic pelvic floor?
Good question.
How do we reverse the ischemia and get the blood flowing again?
The clinical guidelines and pelvic physical therapy literature are unanimous here. Hypertonic pelvic floors require down training.
Down training.
Yes, you have to teach the central nervous system and the local musculature how to let go before you can even entertain the idea of strengthening them.
Okay, down training. What are the actual mechanics of that? How do you force a muscle that has been clenched for years to finally drop?
The foundational technique always starts with the breath, specifically diaphragmatic breathing.
Like belly breathing.
Exactly. When you take a deep, expansive breath into your belly, your diaphragm physically pushes down into your abdominal cavity. This increases intra-abdominal pressure.
Okay.
Mechanically, your pelvic floor, which is the bottom of that cavity, has to drop, lengthen, and soften to accommodate that downward pressure.
It's a mechanical override.
Right.
By expanding the belly rather than sucking it in, you force the pelvic outlet to widen.
Yes, it gently stretches the tissue and begins to restore blood flow. But breathing and gentle yoga stretches, like child's pose or happy baby, are often just the starting point.
Right, because the tension is so ingrained.
Resolving true hypertonicity usually requires the intervention of a specialized pelvic floor physical therapist.
Because it's not just about stretching a tight muscle, it's about breaking a deeply ingrained neurological feedback loop.
Exactly. A pelvic PT uses highly specific techniques. They can perform internal manual release, physically targeting the trigger points and knots within muscles like the levator ani to manually break the spasm.
Wow.
But one of the most effective tools is actually biofeedback.
I've read about this in the sources. How does the biofeedback actually work in a clinical setting to treat laxity?
Well, biofeedback utilizes external surface electrodes placed around the pelvic floor. These sensors measure the microvolts of electricity being generated by the resting muscle.
Okay.
The patient looks at a computer screen and can visually see a graph of their muscle tension in real time.
Oh, that's amazing. So they can see exactly how hard the muscle is working, even when they think they're completely relaxed.
Exactly, because when you've been clenched for years, your brain literally forgets what relaxed feels like. Your new normal is a state of spasm.
Right.
Biofeedback provides a visual representation that allows the patient to consciously recalibrate their brain's baseline. They learn how to consciously drop the line on the graph, which teaches the nervous system how to finally release the pelvic floor.
If we connect this to the bigger picture, treating symptoms without understanding the underlying resting tone of the muscle leads to an incredibly frustrating, painful cycle for millions of women.
It really does.
Like a woman feels a lack of sensation, she assumes she is loose, she does Kegels to fix it, she develops pelvic pain, she goes to a general doctor who says her anatomy looks totally fine, she goes home and does more Kegels because she thinks she just isn't trying hard enough.
Oh.
It's maddening.
It is maddening, and it highlights a massive gap in how we educate patients about their own bodies. This raises an important question about postpartum and menopausal care. If the medical community just hands out a generic pamphlet on Kegels to every woman experiencing pelvic symptoms without first physically assessing her muscle resting tone, we are actively causing harm to a significant percentage of them.
Which brings us to the core takeaway for you listening right now. If you are experiencing pelvic symptoms, whether that's unexplained pain, a sudden urge to run to the bathroom, or this subjective, frustrating feeling of laxity and numbness, the generic internet advice to just do more Kegels might be the exact opposite of what your tissue actually requires.
Precise.
You need to know your resting tone. You need to know if you actually need to strengthen,
Yep.
or if your body desperately needs to learn how to let go.
And if you don't know your resting tone, the literature is clear. you should seek out an evaluation from a pelvic floor physical therapist.
Right.
They are the only specialists fully trained to differentiate between a hypotonic, truly weak muscle and a hypertonic, exhausted one.
So let's do a quick recap of the clinical journey we've mapped out today.
Sounds good.
We started with the highly subjective, confusing sensation of vaginal laxity. We unpacked the Develop a study, proving that the sensation of looseness frequently has absolutely zero correlation to the physical anatomical width of the pelvic tissue.
And then we explored the hidden mechanism of the hypertonic pelvic floor, detailing how chronic tension causes ischemia, restricts blood flow, and builds up lactic acid.
Which is so crucial.
We saw how this acidic environment blunts the nerve endings, tricking the central nervous system into feeling a sensory dead zone that it misinterprets as looseness even when the muscle is completely exhausted and tight.
Yeah, and we analyzed the partner paradox, proving just how unreliable our own sensory translations can be when our partners are hitting a wall of tension while we feel nothing.
Right.
And finally, we learned why the cultural reflex to immediately do Kegels is actually dangerous for overactive tissue, and why downtraining, diaphragmatic breathing, and biofeedback are the true paths to restoring sensation.
It fundamentally shifts how we need to view physical dysfunction. And I think there's a final, broader thought worth leaving you with today.
Let's hear it.
Our sources explicitly note that the body develops this hypertonicity as a subconscious guarding reflex. It is bracing against physical trauma, yes, but it is equally bracing against chronic pain, severe emotional stress, and long-term anxiety.
Wow. It's the body's fight or flight response, literally trapped and localized in the musculature of the pelvis.
Precisely, which begs a much larger question for all of us to consider. How much of the physical disconnect, the perceived weakness, or the mysterious lingering aches and pains we experience in our daily lives is actually just an echo of our own nervous system?
Yeah.
How much of our physical dysfunction is just our body bracing endlessly to keep us safe from a threat that has already passed?
That is a profound perspective. We are walking around clenched, fighting an invisible threat, and wondering why we feel so exhausted, numb, and disconnected from our own bodies. The body keeps the score, and sometimes it needs help realizing that it doesn't need to guard us anymore.
That's exactly.
Thank you for joining us on this deep dive into the paradoxical world of pelvic health. Listen to your bodies, question the generic advice you find online, and never be afraid to seek out the personalized, specialized care you deserve. We'll see you on the next deep dive.